Yes, so we're going to talk about the LGBTQ care in primary care as a nurse practitioner. And so our learning objectives will be identifying, it's quite a bit of letters, but we'll go through them. LGBTQIA terminology, understanding the social and medical context in which lesbian, gay, bisexual, and transgender, I'll probably just default to LGBT to shorten it. So just so we have that understanding. So understand the social and medical context in which lesbian, gay, bisexual, transgender, LGBT patients seek healthcare. Describe major medical and psychosocial concerns in LGBT patients, and summarize strategies to promote culturally appropriate care for LGBT patients. And so what we have here is the whole alphabet. And to provide optimal care for LGBT patients, let's start beginning with the understanding of what these acronyms stand for. So L is lesbian, to refer to women primarily attracted to other women. Gay refers to men primarily attracted to other men. Bisexual refers to those attracted to both men and women. Transgender refers to two groups: those who identify with and transition to a gender other than the one assigned to them at birth, and those who express gender differently from prevailing norms in society. Queer is an umbrella term. It's used by some to describe people who think of their sexual orientation or gender identity as outside societal terms or societal norms. I'm sorry. And some people view the term as more fluid or inclusive. However, due to its history as a derogatory term, the word is not always embraced or used by the LGBT community. Questioning, well, that describes an individual who is unsure about or is exploring their own sexual orientation and or gender identity. Intersex is a difference in sexual development that's caused by hormonal irregularities during pregnancy. But I will describe this term a little more detail on another slide coming up. Asexual, that is a person experiencing little to no sexual uh, attraction to others. And it doesn't have to be permanent, it could change, but if they're asexual, that's what it means at that time, that they're just experiencing little to no sexual attraction. Androgynous, that's a term that describes someone whose characteristics are of both femininity and masculinity. So that's either in appearance, demeanor, or clothing. Allies. An ally is a person who supports another group. Doesn't mean they identify with that group or identify as a LGBTQ, but they are an ally. Like for example, an ally may support the LGBTQ plus community, and they may fight for people to have better work conditions, living conditions, and so forth. But just know that it is important to note that these definitions, they do vary across communities, and that they can change over time. Not all LGBTs people agree with all these definitions either. Okay. I'm not going to go through all of this. I just wanted to put the terminology up there because it's more than what I just named in the alphabet, the LGBTQIA, but there's different, several different terms. So I put them in the slides if you want to come back and access them and look at it and get all the definitions. So, and we have 3 slides. There's quite a few good terms that explains everything. So I put those in there for you, just for your knowledge. Okay, so to start, let's say what to use, what not to use. How about I like to go with following the lead of the patient when I'm talking to them. And I may start off asking them, what terms would you like for me to use? And it may sound a little weird, but it's not weird in this day and time. You can't say what term or what pronouns do you go by, just to get started, to get familiar with your patient. Another thing to keep in mind is that patients that could be LGBT, or they may or may not be, but they also may have family members that are LGBT. So therefore, it's always good to practice inclusive language with all your patients. Say, for instance, like asking a female patient about her partner, and opposed to saying your boyfriend or husband. And that's vice versa for your male patients. And when we're talking to younger patients, um, we like to use the term like your parents or guardians other than your mom and dad, because in this day and time, we know that some young people have two moms, some young people have two dads. And just to decrease the chance of feeling uncomfortable, we like to just use these general terms. I put the transgender terms up there, like trans man, so you may see female to male. When you hear someone say there's trans woman and you see MTF, that's someone who was male that transferred male to female. DSD is affected or intersex. So the difference in the sex development is what DSD stands for, or it's also known as disorders of sex development. Intersex genitals, or you may hear it even in nursing. I've seen it quite a bit working in the Peds ICU and the NICU, that some babies, very seldomly, but we have babies born with ambiguous genitalia where they did present with both genitals. So intersex is a difference in sexual development that's caused by hormonal irregularities during the pregnancy. And I just specifically remember one case when a baby was born. Little boy, he had a penis, his shaft, he had his scrotum, and underneath it, he had there was a vagina present, and he immediately went to the ICU unit, and then they had to run a series of tests of his hormones to see like which sex was he more identifying with. So that was my first encounter years ago working on the PEDS unit, but that is what that is, an intersex. And some parents let their child grow up with both and then let them decide, and then they have to go and get some type of cosmetic surgery. Um, Also, I like I said, I would address someone like, what name would you like for me to use um, for legal or insurance purposes? So, for example, I had a patient before that was a female. Her name was Chloe, and over a few years down the line, she transitioned to female to male, and so she was a trans man, and she wanted to be called Clyde. However, for legalities, insurance purposes, and billing, you have to go by their legal name that's on their ID and on their social security card. So, in opposed to just doing it and writing it down and causing some type of offense, you have to let them know or ask up front, I have to use your legal name or your birth certificate for billing purposes. And that's why I have put that on there. But, and again, like I said, you can ask what pronouns you like to go by. And in their sexual orientation, it could be gay, lesbian, and bisexual, other terms. So it's always good to identify that. Transgender and transsexual, we'll go over that a little bit. Hermaphrodite, that's an organism where a person has both male and female organs, structures, and issues internally and externally. And we don't want to use that term. It's a little offensive. And we don't want to ask people, what's your real name? And opposed to when I said, what name would you like for us to use? So we try to not make things uncomfortable or hinder a patient from wanting to come back. When we say pronouns, we want to say they, them instead of say a he, she, or it. It could be very offensive. And when we use the lesbian, gay terms, is more appropriate in opposed to saying you're homosexual or what's your sexual preference, what's your lifestyle. Is we're just trying to get away from those negative terms. Gender neutral terms is using they, their, them, partner. And I know we're well in the Texas area. We're very hospitable and have these good manners where everyone always says sir or ma'am. And so it's hard to get out of those habits of saying yes, ma'am, yes, sir, but we want to kind of drop the sir and ma'am in another way of respect as far as how they identify, if that makes sense. Okay, moving forward. I just put this little diagram up here um, for your knowledge. Um, so, like sexual orientation, it goes by these terms, and lesbian, gay, bisexual. When sexual development is how they were they born male, female, or intersex. Gender identity, we'll talk about cisgender. Transgender, we kind of talked about already. Gender queer, we'll go over those terms a little later. Now, gender non-conforming or gender conforming. Gender conforming, to explain that, is basically what we consider 21st century societal norms. Like, for example, in the 21st century here in America, it might be considered gender conforming for a man to enjoy watching sports, fishing, hunting, and for women, it might be gender conforming if they're interested in fashion, yoga, knitting. And another example I would give for gender conforming is like a man who has long hair. Let's say he cuts his hair off from long to short because it's an acceptable norm. And gender non-conforming, that is when someone doesn't adhere to society's gender expectations, um, which can include different roles in the household, how they dress, how they behave, how they look in their appearance. Um, so just a quick clinical tip: when in doubt, just ask. Um, Terms change constantly, and they carry different meanings, and they're different for different people. So don't be afraid to ask your patients about their identity. And to show that you're accepting and warm, you follow up with, thank you for sharing that with me, that you identify as gender nonconforming. Please tell me more about what that means to you so I can provide you with the best care possible. And then that lets them know you're open and receptive to their their beliefs or their lifestyle with no judgment. And it makes your visit go a whole lot smoother. Okay, so why is this even important for a primary care provider? Why is this important for a primary FNP? Well, family nurse practitioners are PCPs. Um, and what's important is that the social determinants of health are very affected. Economic stability, we're looking at a form of social isolation, rejection of the LGBTQ youth and families. It contributes to high rates of homelessness and among our youth. Uh, the lack of legal protection from LGBTQ people in housing and employment, it contributes to housing stability and financial instability for this population. Our healthcare, having access to primary healthcare is affected. Our healthcare providers, they lack training, which contributes to patients dropping out of care, avoiding care, not getting their follow-up routine screenings, or they are subjected to receiving substandard care and concealing their information that's very important that the provider needs to know while they're in a healthcare setting. Also, there's widespread of experiences, lots of research that talks about the discrimination in healthcare, which contributes to the delays of preventive care and resulting in poor health outcomes for the LGBTQ community. Another thing is mental health issues, that social and community context. So social isolation of a stigmatized group, it forces social isolation into bars, contributing to higher rates of alcoholism, drug abuse, and smoking. Well, I would say tobacco smoking abuse, because there's a lot of smokers, but some is also ways where it can be abusive. Bullying of youth are perceived to be among the LGBTQ is widespread and it's very common, and it also contributes to poor mental health outcomes for young adults, for youth and young adults. So why else is this important? Well, looking at the health disparities, and I'm pretty sure you know about Healthy People 2020, and we'll be coming out with a 2010, and then I mean not to 2010, but we'll be coming out to 2030. That's coming soon, but this is very important because our LGBTQ, the risk of poor mental health status, and like for one, and these are stats that I pulled. The LGBTQ individuals are almost 3 times as likely to experience a mental health condition such as depression or general anxiety disorder. For two, individuals between the ages of 10 and 12, suicide is the leading cause of death among the LGBTQ. Also, LGBTQ youth are 4 times more likely to attempt suicide, experience suicidal thoughts, or engage in self harm, self cutting, self infliction, some type of way. And lastly, between 38 to 65% of transgender individuals experience suicidal ideation. And those are all serious and they do affect us as practitioners because it comes into our clinics and we need to be able to identify this. All right, so adolescent males. I put this QR code up there. I don't know how if you've been using the Preventative Task Force much, but the USPSTF is the U.S. Task Force, but it's now called the Preventive Task Force. I put the QR code up there so you can scan it. You can download the app. It's very helpful in your clinical settings, especially getting started off, and it gives you access to all those guidelines. Um, so the Preventive Task Force, it recommends screening depression for all adolescents. Um, and however, PCP should still be mindful that gay male adolescents have higher rates of depression than their straight or heterosexual counterparts. Excessive rates of depression is also related to experience of rejection in the home and in school. Depression can also cause significant morbidity among gay adolescents. And that morbidity of what I'm referring to is the suicidal ideations or suicidal attempts. So it's always important to affirm patients, support your patients, but also to educate. Um, we have to, as primary care providers, educate our families as well as their loved ones or their significant others and people who are attached to them, and make them aware of the negative mental health effects that rejection has when we don't accept them or try to be receptive to their change in life. All right, so we're going to move on to understanding sexuality. So identity, a way to identify how you're to understand how your patient identifies. Do you consider yourself straight, gay, lesbian, bisexual? Understanding their behaviors. What genders do you have sex with? Attraction or desire is always important to know. You know, what genders are they attracted to? So to talk about some of the categories. So when caring for lesbian females or women who have sex with women, you'll see WSW. Um, Similar to gay males that we previously talked about, lesbian females exhibit disproportionately higher rates of mental and behavioral health problems compared to straight females, such as abusive tobacco use. alcohol and drug use, depression, anxiety, and also eating disorders. And also higher rates of ovarian and breast cancer. And you may ask, like, how or why? Well, some research studies have suggested that lesbian women may have increased rates of ovarian and breast cancer, which may likely be due to discrimination or negative experiences that they've had within the healthcare system. Studies also show that lesbian women have reduced access to care and preventative services such as those mammograms and cervical cancer screening. So that could explain why the rates may be higher. So remember that sexual orientation is a process, and sexual identity and behaviors can differ. So it's never good to assume. Um, and we want our female population to feel very open and about or candid about their lifestyle, and not feel judged or reserved or get to a point where they avoid going to the doctor altogether and miss those very important appointments. So lifespan over primary care. Let me go back. So again, with the males, it's always important to affirm, support, and educate others. And when we look at the lifespan in primary care, the development of sexual orientation is a process. However, primary care providers should be mindful that gay male adolescents, when they have this higher rate of depression, that oh, I'm sorry, that's the same one. Yeah, that's the same slide. So, looking at the lifespan over in primary care, how people change. When I was giving you that example of a patient that I saw who was Chloe, and then 3 years down the line is now Clyde, we have to learn how to adjust and move with with healthcare. It's changing, and our attitudes and our belief system has to be flexible. Okay, let's talk a little bit about caring for bisexual people. Bisexual people are people who have the capacity for sexual attraction to people of both sexes. Regardless of their biological sex, some may prefer to use the terms pansexual or omnisexual. Others may prefer the term fluid sexuality to describe the capacity for attraction, their attraction to different genders. In spite of the words one may use to identify themselves, it's so imperative that to know that sexual orientation occurs on a continuum, so it could change. And so here are some key indicators. Implementing a culture of humility. Um, Cultural humility is really like an approach that urges the learner, the provider, to look inward at their own cultural beliefs, their values, and biases that may affect the way they provide care. And if you ever heard of something called implicit bias, I'm not sure, but if you look it up, you can also take an implicit bias self-test to just see where you score. Learning visual cues. So learning visual cues indicates for an LGBT patient that they are welcome and they're included, and having clearly, when I say signage, having clearly posted non-discrimination statements that's posted in the clinic, posted in the exam rooms, posted in the bathroom. Um, it includes references of sexual orientation and gender identity. You may see SO for sexual orientation. You may see GI on different literature, which stands for gender identity. The Department of Health and Human Services, they now require that all electronic health records that are certified under a stage 3, which is the meaningful use program, they must have the ability to capture data about their patient's sexual orientation and gender identity. And so, on a practice level, On a practice level, we want to increase staff awareness through nursing education and staff development. Improve communication. Asking patients what their pronouns are, expressing sensitivity to their needs, and expressing understanding. Creating a safe, warm, and welcoming environment. For one, a lot of places are now transitioning into switching bathrooms to the all gender restrooms, and have that in both waiting rooms and facilities that have stalls. They are now putting signs and symbols on the outside of the bathroom where it is gender neutral. I just came back from a conference in San Francisco, and that's how the restrooms were set up. And so you see both male, female, or transgender or whomever coming in and out of the same restroom, but they had the stall set up like like dressing rooms. Like you really, it was closed off, and you go into your own stall, and there's no scene under the door or anything. So it was very nice to have that, and you have your privacy, and you can feel comfortable with whatever restroom you went in. Okay. Uh-oh. I'm sorry about that. Okay. All right. So knowing the difference, transgender. Transgender people are people whose gender identity is different from the gender they were thought to be at birth. So trans also, you may see trans, which is often a shorthand for transgender. So that is someone who probably was born identified as a male and then a transgender and probably even went through the sex change and everything, and now they're female. Cisgender. Cisgender is a term used to describe people whose gender identity matches the sex that they were assigned to at birth. So, for example, cisgender male identifies as men, and cisgender female identifies as women. So, sexual orientation and gender identity questions. This is just some things that you should start seeing on your intake when your MAs are even asking, are intaking, doing the intake, or if you are actually doing the intake. And I'll say why this is important when you to have this literature now. I had an experience in clinic where I was the only provider managing a small community outpatient clinic, and I had a medical assistant, I had a social worker in there, and had two medical assistants, a social worker, and we had like a care team person on board on staff. And I was in a room with the patient, and I recall hearing all this commotion. You hear it right through the walls. You can't hear all the words, but you hear like this vibration going through the wall, and it sounded like someone was it was getting escalated. And I go out to see what's going on, and knock on the door. My medical assistant was asking. He was actually seeing a transgender female, which was a man who has transformed to a woman. He hadn't had the sex change, didn't do any of that, so he's um, just presenting himself as a female, and my medical assistant didn't catch that. So my medical assistant was asking this patient all the female questions. When was your last period? When was your last breast exam? When was after a while, this patient got so irritated, upset, escalated, and it blew out of control. And the patient said, all you had to do was at first just ask me how do I identify. So that was a lesson learned for all of us. That was not on our literature, and now I'm hoping things have changed, but it's a very important because it just disrupted the whole flow of the entire clinic. And then that person never came back and said they were going to tell their counterparts or their friends and stuff. Never come to this clinic, so it could leave um, a bad connotation for you if you're not trying to be open and understanding. That's why it's important. So we are asking, how do you consider yourself? What is your current gender identity? And it is appropriate to say current because things could change. And it's also important to ask what sex were you assigned at birth, because then you'll know what appropriate questions to ask for screening. So, okay, improving communication in primary health care for the LGBT plus. Um, when you're going in there, you're seeing your patient, you do your review systems, just to throw in a couple extra questions to get to know your patient a little better, and especially if you identify some things that they wrote on their intake sheet that like, oh, they're identifying different, and didn't say they're male, female, or they say they prefer not to answer. So to know your patient more, you can ask a couple more questions like, have there been any changes in your sexual behavior since I last saw you? Do you want to talk about your sexual health today? The history form should include the sexual behaviors, meaning do they use condoms? Do they have anal sex? Do they have oral sex? What sexual partners do they have? What are their sexual attractions? Are they attracted to male, female? Always give your patient the opportunity to talk about their sex life, their behaviors, and preferences, but a very open, receptive attitude towards your patient, where it's non-judgmental and they feel comfortable opening up to you. We'll go over a couple of things that's helpful and some things that are not helpful. So understanding your own beliefs to start with, and we are a very big Christian. There's a big Christian society, and those who are Christian in the workforce, and some of you may be Christian, and some things may be against your practices or your belief system. However, we have to be still transparent in our own lives and realize that those are my beliefs, those are my standards. I can't expect them for others. And if I don't see that in others, I can't judge them. And that's what's most important because we don't want it to interfere with um, providing them optimal care or having the attitude of you get what you get, or you put yourself in risky situations. This is what happens. We want to just get away from that attitude, or even if it's in your head, we want to just get rid of those belief systems because people are people and they need to be cared for. And our whole goal is to prevent and to help people get better or stay better, and not affect anything that will um, also impact their mental health. So in your workplace, and some of you may be independent providers and start your own clinics, or you may be in clinics where you see some things need to be implemented. But assessing your workplace policies and procedures, have an implementation of anti-harassment policies, promotion of non-discriminatory practices, be visible, and be an example and lead the way and let others see how you are reacting and let others see how you handle special populations. Responding to anti-LGBTQ language and behaviors, correct behaviors. If you hear it, if you see it, don't engage. Don't laugh it off. Don't blow it off. Say something. And also look to employee and personnel support. What's not helpful is thinking that homosexuality is a disorder. And remember, I know earlier in the presentation, homosexuality is now kind of, well, homosexuality is an actual term of same sex, but to call someone a homosexual, just remember, it's a little more offensive. But homosexuality is a disorder. Attributing all presenting concerns to sexual orientation and gender. So we want to just make sure we understand how people are identifying, and not be one-sided. Lacking knowledge and understanding of the coming out process. So as a provider, and especially if you have a good rapport with your patient, you may be the first person they come out to. So it's good to have an understanding how to respond to that, and then how to educate your patient or guide them with some resources or support them in any kind of way of how you can help them talk to their family, talk to their loved ones. And it's just a well-rounded, holistic approach. We're going to avoid the heteronormative frameworks. And when we were talking about like guys, they lift weights, they cut their hair, they mow, they fish. We want to get rid of these type of frameworks where we just have this open mind. And also expressing demeaning beliefs about LGBTQ. So even if you do have strong beliefs, even if you don't agree with the lifestyle, just remember you look at a person as a patient, and want them to be in optimal health. You cannot control what their life preferences are. And I'll just give you a really quick example of when I was working in the prison system. And as a nurse practitioner, providing care to some of the most egregious or the most dangerous people that was locked up, and I was in an all-male prison. And when you pull up your patient's chart in the prison, you have the whole profile. You have what they're in for. You see what they did. You go through and read case notes and the court records. And I had a very hard time um, dealing with that when I was seeing like a person who was a pedophile that harmed a toddler or adolescent and did some severe damage to a kid, or someone who raped a bunch of women and young boys, and I had to really separate myself from that. It's like I have to make myself not read it because it just pops up on the screen, because it was indeed affecting the way I interacted with the patient. Did I prescribe the right medication? Yes. Did I do a thorough assessment? Yes. Was my conversation wholesome? No. Quick, short, and like, let's go. And I had to confront myself about that because I'm treating the patient. What they did, and that's why they're in prison doing time for it. And I need to take care of their health, and it can be challenging. So that's why I want to share that. So what can we do? Like I was giving you the example of what I did. You have to create a plan. Create your own plan. And change is just ahead. Change could be the next visit. So you have to make sure part of your plan is to be fluid, or to be receptive, or just to be open. Um, think about your workspace, or even like in your classroom if you're teaching, or in your own practice. Think about your attitudes, your beliefs, and perceptions, and write them down if you need to, or take the implicit bias test, or take some other type of bias test to see explicit or implicit. You might, some people are explicit with their behavior and they show it right there in the room with the patient, with attitudes, facial expressions, heavy breathing, sighing, or eye rolling. So many ways to catch yourself and say, hey, am I being the best person or to this person because of the way they are, and opposed to someone who you look forward to seeing every visit, you know? So we need to be like that in all our patient encounters. Think about the policies and procedures where you work, and what is the culture or the environment like where you work in the workplace, and what are the signages that are around, like what needs to be improved. So create your plan, even if it's to come in and say we need to make some changes. I don't own this clinic, but we have so many different patient populations. We need to be ready to receive anyone that walks through the door. And that's also thinking about your coworkers, or if you're teaching in academia, if you go on to be a preceptor, think about the patients and the clients you see, and how we can help this change go smoothly, and make it a better place for everyone. So I want to spend the next few slides. I want to read a case study to you. This is no, there's no pop in questions or like test questions on this. So I just wanted to present a case, um, and I know Rachel, you are managing the chat box, and I'm not able to see anything. But I want to read this case and just get your thoughts on it. So we have Jamie, who is a Latino 14-year-old adolescent who was assigned male at birth. Jamie and his parents are Catholic and are active in their neighborhood parish, which is predominantly Latino and Spanish speaking. Jamie was born with a genetic condition that affects the kidneys, ears, and eyes, leading to hearing loss, eye abnormalities, and progressive kidney damage. With so many other issues, Jamie's oral health is somewhat neglected too. Jamie frequently sees a variety of specialists for his kidneys, eyes, and ears, but you, the practitioner, are part of his primary care team. 2 years ago, when Jamie was around 12 years old, At a routine visit with you, Jamie's mother asked if you could provide a referral for a therapist. She felt that Jamie started to become sadder for no apparent reason, and his grades in school started to slip. You referred Jamie to a therapist who works well with depressed adolescents, wondering if his chronic physical problems are affecting his mental health or if his medical problems have made him a target for being teased at school. Several months have passed. The therapist recently reaches out to you, Jamie's primary care provider, at the request of Jamie's parents. The therapist sounded an alarm, reporting that Jamie mentioned in a session that he thought he was having crushes on other boys and questioned the counselor whether he might be gay. The therapist commented to you, I don't really specialize in these issues. Shortly thereafter, your staff received a call from Jamie's school indicated that he made a suicidal statement after an incident of being bullied. I just don't know if I want to continue living anymore. You learn that the therapist shared with the parents that Jamie thinks he might be gay, later stating that it's okay to break confidentiality because of safety issues is at hand. The parents repeatedly asked Jamie if he might be going through a phase. So, fast forward, Jamie is now 16 and has come to your office today for a routine checkup. Your clinical assistant goes to the waiting room and looks for a teen male but cannot identify one. After calling the name Jamie, an adolescent with long hair wearing makeup stands up. The assistant acts surprised and nervously states, Oh, you weren't what I was expecting, eliciting stares from other patients and people in the waiting room. During your clinical visit, Jamie notes that their feelings of depression have gotten worse and have the symptoms of and having the symptoms of their genetic condition as well. As part of your conversation with Jamie, you ask, at this point, what gender do you identify with? Jamie looks surprised but says, I'm not sure. But I don't know. I feel female and I feel best when I'm dressed in this way. You ask Jamie, what pronouns would you like to use? Jamie responds, they and them works for me. Seemingly relieved that you have asked these questions, Jamie tells you about the Gay Straight Alliance at school, report that even though this year has been difficult, that they feel safe with this group. Jamie also tells you that even though their parents had initially struggled with the idea that Jamie might be gay, they now accept this. Jamie's parents have told Jamie that they love and support them no matter what. You ask Jamie, how are they coping with having you see so many specialists? And Jamie replies, it's hard, you know. The doctors understands kidneys and stuff, but I don't get treated nicely because I look different. Okay, so this is where you come in the chat. Let's debrief. And let's just start with the first questions. Is Jamie gay? Is Jamie transgender? Or how could you figure this out? And I'm not able to see the chat. And you see any answers in there, Rachel? Okay, and we'll go to the next one. How do Jamie's social identities affect their health and the care they receive? And let me see. Let me see if this. A third question is you can think about what key concerns do you now have about Jamie's health and healthcare? And lastly, something else to think about is from both a clinical and also non-clinical perspective, what strategies would you recommend to meet the needs of this patient? And these are critical thinking questions or skills that you will have to utilize when facing these types of situations. Jamie does have indeed chronological illnesses due to his his birth defect, or that he was born, that's affecting his kidneys and his eyes and things. But now he or does now they, because remember, see, I just did it. It's hard to switch when you've seen someone for so long and you identify as he, and now it's they, them. So I just did it. And it's so important. Just take your time, slow down. But if you do catch yourself saying, okay, so I see you, or you call him, say him or he in front of the patient, just correct it, catch it. Oh, I'm sorry. They're not meaning if it's they or them. And just correct it. Let them know that you're trying to understand and that you're working with them. But I hope you were able to put some comments in the chat. I'm not able to see the chat. Rachel must have to step away. But these are the things we would think about in caring for a patient with this kind of case, how it's built up over time, and you've known this person since they were little. And though they haven't changed their names, they still go by Jamie, but they don't want to be called he anymore. And now you have to go by they, them. These are things you have to think about how to conform as you're providing optimal patient care. So yeah, that is pretty much it for my presentation. I hope you enjoyed it and got something out of it. I want to move on to just tell you about our to review FNP, give you some information. We do have a live review coming up September 13th through the 15th. Be sure to scan the QR code for that. Remember, at the Archer Review website, we have those question banks where you can get a free trial of 1,500 plus questions, readiness predictor that tells you how you're scoring, um, and the on-demand hours, 13 hours of content, and little bite-sized videos. We're starting to do these reels, so make sure you're following us on Instagram, Facebook, and tap into our reels. They're questions of the day every day. Go in there and just test your knowledge. You'd be happy when you feel good that you got those answers right. And if you didn't, then it's a learning opportunity. And just to put in your index, Rolodex, like, okay, let me look more into that. So make sure you're tapping into our social media websites, and every day is going to be something there. Monday through Friday. The live review is going to be very good. It's a 3-day review with a live expert instruction. Review the must know topics and all you need to do to prep for your exam, your state board exam. But we'll also have like a workbook that you can use as a reference, that electronically. And so it's lots of resources for you. Just so please connect with us. All of our connections are right here on this page. You can also email us if you have any other questions. I think I'll probably do this presentation again, add a little more content, and build on it. So look for this again if you want to know more. I'll probably come back around sometime before the year's out and do this one again. But if you have any questions, I'm not sure if Rachel's back. I'm not able to see the chat. Um, you can also unmute, I believe, if you want to say something out loud and just ask. I can do that. Um, let's stop sharing. Let's see. Okay. So if there's nothing else, I guess I will let everyone go.